Welcome to this new webinar on the AI Frontiers series. And today it is my great pleasure to bring you to our Liane Canas. Liane is a King's AI Plus Fellow in the Department of Biomedical Engineering at the School of Biomedical Engineering and Imaging Sciences here at King's College London. She completed her master at the University of Lisbon in 2015, focusing on multi-center studies for disease diagnosis. Then her PhD was at the University College London and was focused on the automatic extraction of imaging biomarkers to characterize prion disease. In her current research, she develops machine learning models to investigate infectious and neurodegenerative diseases by integrating both imaging and textual data. At King's, she's involved in projects that merge biomedical imaging, digital health, and precision medicine, with a particular emphasis on using digital twins for personalized prognosis and treatment modeling. Her work aims to advance responsible, interpretable, and equitable AI solutions that can be effectively implemented in clinical practice. And with that, I give you the room, Liane, and looking forward to your talk.
Thank you, Pablo. Thank you for the very kind introduction and for having me here today. So, as mentioned, I will be talking on the topic of the next generation of preventative healthcare, trajectory modeling for the personalized health management. But why this topic? Why is this an interesting topic nowadays? So the healthcare system are facing challenges in meeting the population needs for both the diagnoses and treatments. And if we think about it, there is a pressing need to improve the speed, the accuracy, the robustness, and actually to provide more personalized diagnoses in order to reduce the strain on the healthcare and enhance as well the patient's care. But how can we achieve this? So if we think about it, in the majority of the cases, what happens is that the clinical onset is detected by the observation of given symptoms. So then the subjects are led through the normal clinical pathway, which includes examination and clinical history, immediate tests, or even more complex exams like imaging. And after that, they can go either under admission and treatment, or they can actually be discharged and just follow up on their symptoms. But it would be quite interesting and relevant that we could get these patients even before the clinical onset, and leveraging other type of information like genetics, imaging, demographics, and behavioral, we could anticipate some of these changes, doing the modeling and the prognosis based on these kind of biomarkers and information, and do a more target and personalized treatment, which hopefully would lead to the mitigation of some of these symptoms. However, in both of these scenarios, we are still acting on the disease front. So we are acting on the clinical onset. But it would be very interesting if actually we could leverage all of the information from these biomarkers here above to actually act it before the clinical onset, in the sense that we could model these biomarkers obtained from screening programs or even from other different admissions of these subjects to intervene beforehand. And by intervening means in developing interventional frameworks, and interventional frameworks that could act by changing the habits of these subjects in terms of food intake, in terms of physical activity, or interventional frameworks even in terms of acting with medical care, and then doing the completely minimization or even elimination of these symptoms. So this would be a more proactive and preventative approach to manage this individual's health. But that means that we need to go from disease progression models to active preventative models. And what this means is that if we go from the models that exist nowadays, which in most of the cases are sequential and discrete, and could include simple models like statistical models like ARIMA, to more complex models like transformers, we could model these biomarkers as time series. And this is actually good and provides accurate predictions. But as I was mentioning, these models in the majority of the cases, they are discrete, which means that they only deal with data that has been acquired for evenly spaced time points. And the outputs that they predict in terms of outcome of patients are also discrete. We could potentially use more complex models that are meant to deal with complex sets of features like manifolds or VAEs. And we could go even beyond that and use generative AI to deal with missing data, which often happens in clinical settings, and try to fill the gaps with basically the generation of the missing samples, but also using generative AI to predict the outputs of these subjects for unseen time points. But once again, all of these models are still on the realm of the discrete predictions. So to try to overcome that, we could lean towards continuous models. And in this case, we have the examples of Gaussian process and neural processes. But both of these models have the handicap of being quite complex and difficult to optimize. So we could potentially bring all of the knowledge and experience from the clinical setting and the understanding from the evolution of the disease from the clinical environments to bring that as a prior information and a prior for these models to facilitate their optimization. And in this case, we are working on the realm of mechanistic models, and we could have physical informed neural networks, differential equations, so on and so forth. But in all of these cases, what happens is that we are still working on establishing relationships, and in the majority of the cases, kind of correlations between what we see as a symptom and the evolution of the disease. And given that, we wouldn't be able to establish the causal relationship between what could be the interventions that I just mentioned, the symptoms that we are just seeing, that would enable us to do the simulation of different outcomes and the different outcomes promoted by the different interventions. So for that, we would have the causal and counterfactual models, which are still sometimes quite different from the continuous models that I was talking. So ideally, what we would like to do is focusing on this area here that comprises the intersection between all of these different models. And this is what I see as useful for the active preventative models that I was talking about. It would be continuous causal dynamic models that would have as key properties the fact that they can deal with continuous time series, which would be governed by causal mechanisms. These causal mechanisms would allow us to do what if questions. What if I change the food intake? What if I do this intervention? How would the subject react? How would the patient respond? It would enable us as well to do uncertainty quantification. And more than that, would enable us to do a forward simulation of the symptoms, but also a backward understanding of what led to that progression and to that disease. The type of models that we're talking about, and given the fact that this intersection between all of the different types of models would be differential equations, physics-informed neural networks, and even continuous normalized flows. And this would be applied for digital twins to enable us to do patient-specific simulators. It would enable us as well to do prognosis, so a continuous risk estimation under the different interventions that we are proposing for the subjects. A simulation of the impact of the different counterfactuals, and have in mind that here the counterfactuals comes from the causal models that allow us to estimate which symptoms are more relevant or which interventions have a higher effect. And then this would enables us as well to do some clinical pathway optimization, which means that we would simulate the full path for the subjects from since they enter a screening program till they are treated. So of course, that's to have this kind of models, we need to leverage and to have good data, which would include from 4D to 2D imaging data to 1D arrays that would include all of the tabular information that we have either from lab tests or from clinical history. And this is where I want to go, from these typical disease progression models for the active preventative models that I mentioned. So having that in mind, my research has been paved and actually focusing on the establishment of these relevant biomarkers, firstly, from imaging data, and then how can we use these to do the prediction of disease progressions. But more than that, I wanted to go further, and I wanted to try to not only study the diseases in the context of research, but being able to use case scenarios of prospective clinical trials in certain cases or prospective clinical data that could actually change the behavior and the patterns that we were seeing for the disease. And these were the other projects that I will talk about today. So, but starting with the first one, where I had the chance to do Bayesian models for prion disease diagnosis and prognosis. So prion diseases, and in this case, maybe you have heard of it as mad cow disease. It was quite prevalent in the late 90s, and it was a set, and it still is, a set of rare neurodegenerative conditions which show a high rate of progression, and they are highly heterogeneous in terms of phenotypes. So typically the patients die between 6 months and 2 years after onset, which limits the capacity for us to acquire data. But these different phenotypes means as well that the disease goes often underdiagnosed and can be mistaken by other types of dementia. The difference between prion disease and dementia is though that it doesn't follow a monotonic behavior or monotonic pattern, and the features that we see in terms of brain imaging can be quite different from subject to subject. So this means that it's quite difficult to apply AI models and machine learning approaches to actually study this disease. And this gap inspired this project. So the question was, how can we use all of this multimodal data that we had, or multi-sequence in this case, to extract quantitative, meaningful biomarkers that could potentially be used for either the classification, targeting the problem of the differential diagnosis, or for biomarkers modeling, which would allow us to do early diagnosis, for instance, but as well prognosis, and potentially would have the possibility to be used in the clinical selection for clinical trials. So, but having that in mind, we still have the same problem as before, which is the fact that for certain clinical cases and certain clinical diseases, we have the struggle on dealing with heterogeneous data and also small sample sizes. So to target the first one, I start using the multimodal data and leveraging the different information that we can collect from the different pieces that we have available. And once we have done that, it's crucial to define subject-specific biomarkers that would allow us to characterize from different sources of information the disease. Once we have done that, we still need to deal with the fact that we have a small data set, because it's a rare disease, but because it's often also what we see in the clinical setting. So for that case, we need to pick models that are robust, even when we have highly uncertain and incomplete data sets, and can also provide measures of uncertainty so we can fully understand why is the model doing this prediction and what is basing itself on. So the choice for that, it's actually prioritizing probabilistic frameworks, and in that case would be Bayesian models. So the model that we decided to use, it was a Gaussian process, but in this case, we selected an additive Gaussian process. So the reason for that is because it deals well with this kind of data sets, but also can provide measures of uncertainty. The additive structure was due to the fact that we wanted to preserve the information that came from each one of the different MRI pulse sequences without deleting or removing information that was contradictory from the different sequences. So once we have done that, we could have a model that could be used both for the differential diagnosis, but also for the prognosis of the disease. The key difference was the way that we selected the kernel functions, which was done using an automatic kernel design to pick the best function for each one of the different set of features and for the different tasks, and using a kernel that would only be used for prognosis, which would encode the rate of progression of the disease itself. So for the sake of time and the interest of this talk, I will only focus on the differential diagnosis. And we try, as I mentioned, since prion it can be mistaken by other types of dementia. One of them, it's actually the young onset Alzheimer's diseases, here represented by this column. And we try to differentiate prion, the two forms of it, the sporadic one and the inherited one, from the young onset Alzheimer's disease. And something that we noticed, it was even if it was a rare disease and it was very heterogeneous, which can be challenged to do or to use machine learning models to diagnose this disease, we could do it with an accuracy of 75%. And more than that, we could as well distinguish the typical type of IDP that was most commonly mistaken by a young onset Alzheimer's from the type of dementia that we were doing. So the very interesting thing about this study, it was the fact that we could enhance the understanding of prion disease, but also trying to do the selection of some of these patients for clinical trials. It was the first attempt to use a machine learning model in a very challenging situation to have a real clinical impact. However, in this scenario, I was still using research data, so high quality data from a retrospective study. And so it was quite of a different setting. And I wanted to test what would be the impact of using AI and machine learning for prospective studies and for real data that was not at the same standards as prion data. So that was what led me to the COVID symptom study. So the COVID symptom study emerged actually with the COVID pandemic that we all know about. So during this pandemic, when COVID emerged, the primary challenge was actually the lack of understanding that we had about the disease, which included the fact that we didn't know much about how it spread and actually the patterns of symptoms at the early diagnosis. Additionally, there was a huge challenge, logistically speaking, with the way that people were being tested. So not always the tests were available when they should have been taken, and not always the people were testing as much as they should. So given that, there was a need to collect as much data as possible about this disease and try to understand how could we answer these questions. So for that, a multidisciplinary team from which I was part of, from researchers in King's, but also in Europe and the US, partner with Zoe Limited, who developed an app that collected self-reported symptoms. And these symptoms could be simple things like, have you coughed today? Did you experience fever? Are you stressed? But also on top of that, some demographic information and some information about ongoing comorbidities. So this actually resulted in more than 4 million contributors with more than 500 million daily assessments of COVID self-reported symptoms. So this was exactly the opposite scenario that we had from the prion disease work that I did. But of course, that with this kind of data, we faced other challenges. Due to the self-report nature of the data was noisy by nature, and it was potentially biased towards the populations that were reporting. So our challenge or aim was, how can we deal with that, and how can we develop robust models that can cope with these challenges? So the key points, and the first thing, it was addressing the self-reported data and developing data extraction and curation methodologies that could be robust to that. So something that it's a paramount when we are using ML, it's the quality of the data set. And that was what we wanted to be sure that we were addressing at this stage. Once this data has been collected, we could do the early detection, disease profiling, hotspot detection, but also disentangling the symptoms that could be either COVID, either just stress of being isolated, and later on even symptoms of vaccination itself. So given the fact that most of my research focus on the temporal modeling, I will focus here on the early detection and disease profiling. So starting with the early detection. So at this stage, as I mentioned, the pandemic was going on, and what we wanted was models that could be, first of all, robust, that we knew how to work with, and also could be interpretable. So we were not looking for technical advancements. Given that, I used the models that I was previously using for prion disease, in this case, Gaussian process. They could cope with noisy data, we knew that, and they could cope as well with the fact that we needed to have some measures of uncertainty of what we were estimating. We were doing the prediction just using 24 hours of symptoms up to 72 hours of symptoms. But something that we wanted to impose in these models as well, it was a hierarchical structure. And the reason for that, it's because we wanted to encode variables that would change all the time, over time, in this case, the symptoms, but also variables that were static and they were just common to the subjects. So the hierarchical structure would encode first what was the features that would characterize the subjects. And here we have demographics, location, habits, so on and so forth. Then we would compare these features across the different population strata that we had, and that the last layer of our hierarchical structure would have the features that were actually encoding the symptoms. Once again, coughing, fever, stress, over the time points that we were collecting. So the model was actually quite effective in detecting COVID, or at least highlighting subjects that should go for testing, even just with 1 day of symptoms being reported. And given the fact that at the time NHS was using an algorithm to advise for testing that needed 3 days of self-reported symptoms and used only 3 symptoms, when we compared our results with the NHS, we could see that our model, here represented with HGP, was much better than the NHS one. So the NHS would only have 67% of accuracy in detecting these subjects, while we were at the realm of 80% of accuracy. So this was the first hint that maybe these kind of models could have an impact on real clinical guidelines to treat and to diagnose patients. But most interesting than that, at least to me, it was the fact that this structure, the fact that we were using kernels and the fact that we were using a hierarchical structure would allow us not only have a good performance, that's good, but would allow us to have a better understanding about the disease and which symptoms were more relevant to detect the disease for the different population strata. So when we look at the case of the age, using it for sensitivity analysis, for populations under 40, we could see that the loss of smell was the most relevant symptom, with just fewer impact from the other symptoms being reported. However, when we looked at a population that was over 8 years old, we could see that the loss of smell was not even selected anymore. So the symptoms that would be rather more relevant would be diarrhea, high soreness, unusual muscle pain, and chest pain. So if I go back, the majority of these symptoms were not even identified for the youngsters. The diarrhea was not at all a relevant symptom for the early diagnosis. So this means that we could, for the first time, to start having personalized models to characterize the disease diagnosis and potentially the prognosis as well for a specific disease. So the NHS guidelines of a set of symptoms suits all was not the most pertinent one, perhaps, to use. So, but then that brings the question, okay, if we can profile the symptoms for the early signs of the infection, can we also profile for the long-term effects of a disease? And that's actually what we decided to do. So by the end of 2021, we were no longer in the need to act quickly to try to understand how to tackle the spreading of the disease. We were more concerned actually on how can we characterize how this disease affects subjects over time and has an impact in the population. So we used the 3 main variants of the virus that we have in the society, so the wilds, the alpha, and the delta, and we tried to do the profiling of post-COVID syndrome. But the issue here, once more, as I mentioned, data is the key when we are defining these models, was how can we start doing a data curation that is robust to the fact that there is no clear diagnosis of this syndrome, and we need to try to develop models that are robust to that noisy data. Once we have done it, and given the massive amount of data that we had, we needed to do some data aggregation per week to also be sure that we were not including subjects that were stopping reporting over the weeks. And then using this data to optimize temporal clusters that would allow us to do the symptoms profile per different population groups and study these clusters' impact on the daily activities that the subjects would have. So I will just present for the wild variant, but we did the same kind of analysis for the rest of the variants. And something really interesting that we found is that certain symptoms were common to all of the clusters, as is the case the central neurological one. But then each one of the clusters was actually showing a predominance of symptoms from different groups, completely different. So in the case of the cluster A, that we define it as cluster A, it was mainly showing symptoms from the cardiorespiratory system, whereas the cluster D was the only one showing symptoms that were related to abdominal. So once more, we start seeing evidence that we need models that provide personalized characterization of a disease and personalized care, because the same syndrome, a same disease can manifest differently across the different subjects. So when we use these symptoms and these clusters to see the impact on the daily activities of these subjects, we start seeing that it's not only about the profile of the symptoms themselves, it's also about how these symptoms impact the people's lives. And we start seeing that the cluster B, for instance, which was linked to systemic symptoms, was the one that required more medical attention for longer for these subjects. In the same way that cluster C, that was linked to upper respiratory, they were not looking as much for medical health care, but they were experiencing a severe impact on the daily activities. So once more, we start establishing the need to have different treatments and different interventions and approaches for different people, even with the same disease and with the same syndrome. But the problem was, as I mentioned, during these projects, we were using something that we knew, models that were already interpretable and were already robust. But I was eager to start leveraging the wave of AI and deep learning to start doing progress in terms of the technical aspects of this model, to try to move them forward and to have even better predictions for different types of diseases. And that brings me to the next project, where I had the chance to do the prognosis of tuberculosis meningitis. So for this disease, which is quite similar in the way that behaves as prion, so it's an infection disease, it's completely different from prion, but it also shows very heterogeneous phenotypes in the brain, as we can show from this image. So it can manifest in a different way. It's also fatal without treatment between 4 to 8 weeks, and it requires actually the target treatment for the subjects to try to see if the treatment is working or not over time. So the very interesting thing about this project also was the fact that we were collaborating with the Oxford University Clinical Research Unit in Vietnam, and that meant that we had access to a prospective trial data set. So subjects were being treated at the same time that we were acquiring the data, and it was a completely different data set from the UK population, so it was Vietnam, and that was quite interesting to start dealing with all of these other challenges while developing these models. So the aim of the model in this case, it was in one hand to do some technical advancements, and at the time LSTM was still quite new, so this is work from 2021-22, and we aim to do the temporal prognosis of the patient using multimodal assessments, and I will dive into that a bit later. We wanted to do the identification of clinically relevant features over time, over the period of the trial, and as well to identify which brain features were being more useful and more relevant to do the prognosis of these subjects over the period that they were being followed. So that meant that we needed to have data from the clinical assessments that doctors were doing, clinical history and treatment as well as the imaging data. In this case was MRI. And once we have that, we would try to predict what is the output of the subjects for the next time point in the prognosis kind of manner. The challenge was, since this was a clinical trial and the patients were quite sick, at certain points, not all of the information was available all the time. So we could have different kinds of missingness for the different time points. And we needed to cope with that to do the prognosis. But on top of that, since we were following these subjects in the prospective manner, we could as well to use the previous prediction, but the real one, in this case, the previous outcome, to try to update the model to not keep doing wrong prognosis if that was the case from the previous time point. So the model needed to be flexible and to cope with the possibility to use real outcomes to improve the prediction of the next timestamp. And that's the ultimate goal was actually doing the outcome prediction given the treatment for these subjects. So the model that we picked or that we developed needed to be robust to use multimodal data. So in this case, both imaging data, but also the clinical data that we had. So we use an LSTM to encode the temporal behavior of our data sets. But on top of that, we needed to have a tailored loss function that could cope, first of all, with the distance to the assessment that we had, and the assessment could be the imaging, could be the clinical data, so on and so forth, and as well, basically, what is the time displacement between the assessment that we are acquiring and the outcome that we want to predict. But firstly, we wanted to provide the clinical partners and team basically what the model was suggesting as the most meaningful feature in a given time point to predict the next one. And we did that through the occlusion sensitivity analysis, where we found out that the typical features like vasculitis and tuberculosis were actually the ones being picked up by the model. When we used the model for the prognosis of the next time point, we could see that the model was very accurate in the prediction of the extreme scenarios, so less severe to most severe, and a bit more fuzzy in the middle, which is quite expectable given the fast progression of the disease and the fact that these patients were under treatment. But most importantly, we wanted to see what is the horizon in time that the model can cope with to do the prediction of the outcome. So if we acquire the image now, can we predict the outcome in 10 days? And in that case, the model was able to predict changes in symptom severity when they increased quite accurately. But then the performance of the model started generating after 30 days, which means that when we try to develop a model that is personalizable, to try to see the effects of an intervention, often we need to keep feeding the model with more relevant and more present information, more recent one as well, to have better predictions. But everything that I have talked so far is about disease and disease progression. Even though we are trying to do personalized models, and even though we are trying to cope with different interventions for these subjects and see the effect of it, it's still focused on the disease. And that brings me to the next project. So I wanted to move forward from the disease to how can we study something to cope with before the disease. And one way of doing that is seeing how the body is aging, how different organs are aging, and how can we study the difference between a healthy aging and an aging that has some promoters that can lead to abnormality and eventually to pathology. And that brings me to the Twins UK imaging study, which is multimodal, but also multi-organ. So the Twins UK, it's a data set that has been followed for over 30 years. So we have a richness in terms of longitudinal data for clinical assessments, behavioral, demographic, but also genetic information, which we are now aligning with imaging data. And this includes cardiac imaging, pulmonary imaging, Dixon, but also multi-sequence for brain imaging and spine. And the main aim here is trying to study how can we leverage all of this information plus the longitudinal information about the behavior of these subjects to study what are the promoters of unhealthy aging. And of course, that the main advantage of using the twins is that we can regress out the effect of genetics because we have the pair of the twins. So before start doing that, once more, we needed just to create a data set that was rich enough for us to characterize all of that, and a data set that we could automatize to extract biomarkers and imaging-derived phenotypes through ML, and also with QC automatized pipelines to then start developing the models that I mentioned. And the way of doing that, it was just leveraging this web browse platform where we could not only store all of the data, but we could as well potentially deploy it, which we did, all of these pipelines to automatically produce all of the data that we needed. Once we have done that, the question was, where do we start? We have a multitude of information. We have multi-organ information as well, but it's quite challenging to do an aging model in terms of multi-organ. So we decided to focus first on the brain because it's something that I'm used to work with and it's something close to what I have done before. So the main aim of the first project was trying to, by leveraging all of the information that we had imaging-wise, but also clinical-wise, to establish which imaging features could help us to characterize the brain profile in terms of aging, and which factors from genetic, clinical, and behavioral could be associated to possible differences that we see between twin pairs. So to do that, we start doing causal models, and in specific, causal models that would allow us to do the disentanglement between what are the genetic factors, here represented as threads, from what are the environmental factors that are affecting different brain regions. So for an example here, we are just focusing on volumetric information, but we could disentangle that certain regions were mostly influenced by genetic factors, whereas those others connected to language, for instance, and cognition, were mostly linked to environmental factors and were unique across the subjects. So once we have disentangled what is environmental and what is genetic, it means that once more we can start diving into interventional pipelines to act on the ones that are more susceptibility to environmental factors. So we have done that. Through a more complex analysis, we pick different subjects and focusing first on the monozygotic ones, so the ones that share the same DNA completely, we were trying to see for the ones that show differences in terms of brain phenotypes, which features that could be just lifestyle as smoking or physical activity or education or even comorbidities would affect the most and would be the answer to see these differences. So for instance, taking the example of the vessel morphology, it seemed like differences between twin pairs were mostly influenced by anxiety and stress. We could do the same as well for dizygotic, and we could see that for subjects that only share 50% of the DNA, they were not only influenced by all of these environmental features, but it meant potentially that these environmental features plus difference in the genome would be the answer for the differences in terms of brain profiles. So this was the first step to start defining where should we do the intervention and how and which type of intervention as well. And that brings me to the last part of my presentation. How can we now use this AI-enabled temporal modeling to develop digital twins, to do the interventions, and to move towards a preventative healthcare? So the mindset behind this and the vision is that if we fully understand temporal system any time series, we can anticipate the changes that the system can have and enhance the precision that we have for the outcomes of this system. When I say system, this can be general, can be applied to anything, even to a car. How is the car braking after just driving this many miles, or if it has a tire with this many defaults? But in this case, I want to apply to the healthcare. And the reason for that is because I believe that we can establish a new standard for temporal aware digital twin, which will enable us to do proactive frameworks to anticipate change, which not only walks towards the preventative healthcare setting, but also enables the subjects to take control of their health status and aging. That means that we need to focus on the development of generative models that are data-driven, but also incorporate the priors from the clinical setting, and being also theory-based. We need to create digital twins that can change and can cope with change of interventions over time. And we need to develop models that are multisystemic. We know that aging doesn't affect only one organ, but it's actually the interaction between them. And hopefully this will enable us to do the prognosis and timely diagnosis as well as interventions. And it will enable us as well to do an optimization of the clinical pathway of these subjects between the healthcare system. So given that, I believe that we should focus on 4 main domains of research, or at least 4 topics of research that we should initially to focus on. So the first one, it's developing models that can deal with sparse and multimodal data. Sparse in the way that, as I mentioned, in the clinical setting, we don't acquire evenly spaced samples. It's whenever the patient comes, and we need to have models that can cope with that, given that the majority of them trust that we have homogeneously sampled data. And it can also cope with different missingness at random of the different assessments that we have. Once we have that, we can have the model that establishes the progression, in this case for aging, as I mentioned, for a given organ. If we have that prior model or that initial model, then we can start studying through counterfactuals and causality which interventions will have an impact on this aging. So if we consider that this aging can start becoming abnormal, what happens if we change the diet? What happens if we put the subject under certain treatment or suggesting more physical activity? Can we actually revert some of these changes back to normality to have a longer and healthier life? In the same manner, we need to acknowledge and start understanding when and how should we do the screening of patients between healthcare? Not all of the information is useful, and not all of the information is useful at the same time. So it's paramount that we actually can understand when should we do the follow-up and which kind of information should we retrieve to have the biggest or the most profitable outcome with the reduction of the symptoms and the abnormal signs of aging. And of course, that once we have done that, it's essential to start incorporating the interaction between the different body systems. So the priority here, and it's something that I'm working on, it starts moving from just modeling the brain to see, for instance, the interaction between brain and heart, or the interaction between brain and liver through inflammation processes, so on and so forth. So given this vision, the first step, and that's my current work, is to work on this continuous modeling of the biomarkers that allow us to do the imputation, because we don't know where are we studying this subject. We don't know if the subject is in this time point or that time point. So we need to fill the gaps on the time series, but also then to do the extrapolation to predict over time. The kind of models that I'm diving into, it's all of the differential equations ones and the physics and neural networks. And the main issue with these kind of models is the fact that currently they are not using counterfactuals. It's something that they don't incorporate, and they are still not optimized for the imaging domain, where the size of the data it's quite bigger, because we are no longer dealing with 1D, but 3D or even 4D kind of data. And this is the focus of my research. So I have two test cases for this. So the first one, it's using tumor interventions, and this is the best kind of setting to test these models, because we have different interventions that have been done to subjects, which means that we can simulate what is the effect of a given intervention and actually have the ground truth to see if the model is robust and impactful in that prediction. But on the other hand, I'm also focusing on the modeling of the brain aging, given the data sets that we have in hand with Twins UK imaging data sets, and as well the UK Biobank. And this is the current focus of my research. So just to conclude, I had the chance to work with ML models that are multimodal for the early diagnosis and differential diagnosis. And something that I learn and I verify with these kind of models is there is the promise of using them to try to see what is the effect of modifying therapies for the different subjects. But more than that, we can also use AI and ML models to do real-time surveillance, to establish new policies, and to do public health strategy in the way that we deal with subjects. It's most important as well, we need to focus on the development of models that are subject-specific and that they can cope with the clinical data that we have. And this is all of the experience that I collected from these projects that I just presented. But it's time as well to move forward. It's time to unify what is a data-driven model with the clinical expertise that we have from the clinical setting by incorporating physics-informed models. It's paramount that we can use causality and counterfactuals to simulate the effects of the different interventions that we can do to subjects. And of course, as I hope that I convinced you so far, we need to focus on continuous modeling, because it doesn't make sense to treat the treatment of patients or the progression of a disease as a discrete kind of time series. Hopefully, this will lead to better health and a better healthcare in general. It will empower the subjects about their own health status, and ultimately could lessen the strain that we see in the healthcare systems. And it's very curious that World Health Organization, it's actually focusing on aging and healthy aging. They established the decade of healthy aging. So we could potentially start focusing on the definition of actionable insights to do or to move from reactive treatments to timely prevention of some of the diseases that we are currently facing. Just before finishing, I would like to acknowledge all of the people that have been working with me. As you can guess, this is not the effort of just me. It's actually a long team, and it's many more than are just mentioned here, but also to all of the study participants, because the majority of the work that I have done was actually using real clinical data. And last but not the least, I'm very excited about this topic. So if you are eager to collaborate, please don't be shy and reach out. I would be very happy to continue these kind of discussions. Thank you.
Thank you very much, Liane. It's been a beautiful journey. It's been a beautiful talk. Congratulations on all the achievements so far. And indeed, I was really, really impressed by the last slides about the vision and how we can then move these things forward. Audience, we have the Q&A dialog box open for your questions and comments. Please start using it. Please start writing those questions there that I will then read to Liane, and we can keep this dialogue going for another 15 minutes. That I understand is the time we have now to learn more from her. So then, if nothing comes, I have been taking some notes at my end, but please, audience, bring those comments there. I was, let me just come back to where I left. No, I'm not being able, but I guess that the overarching question that comes while listening to you is how sophisticated or how what's the many of the questions you were asking or you were poking, I will naively think that we can dive into them with simple correlation analysis. And I know it's a very dumb and initial analysis, but I think that you can establish those bridges. So probably it's a matter of a scale, and probably is a matter of what's behind correlation and what's the actual causality. But can you give us a bit of a couple of extra key pillars where a simple correlation analysis is never going to succeed, and we need those extra causal links and extra statistical variation approaches?
Yeah, no, definitely. So I actually will start the answer from a different perspective. Correlation can lead us very far away, actually. The kind of models that I was using that rely on kernels, if you think about it, a covariance, it's not exactly a correlation, but it's a close call from it. So we are establishing similarities between the subjects, and we have seen that these models can be very effective. The issue is, and here is where is your question, and it's really interesting. A correlation describes what we see. A causality tries to infer reasons for why are we seeing this. And this is a completely different mindset. So we go from describing what is happening and even trying to predict, which is very useful. It's what we have done for many, many years with disease progression models. But we need as well to try to modify this and go to the realm of, can we understand why is this happening? And what happens if we change this? And this is where causality brings the knowledge. That's not correlations anymore, and we need to dive into causality for that. It's the only way where we can move from okay, we are no longer interested in just describing what we are seeing, we are interested in modifying what we are seeing, and to that we need to understand how to modify and what is impacting that. And that's why I believe causality can bring advantages that correlations, or at least the current models, cannot. I hope that answers to your question.
Yeah, it's quite relevant, and indeed that it's a kind of magic in my mind, indeed, that by analyzing the data you can go beyond the correlation, and I guess that it all boils down into how you design that experiment before testing for the causality, and as you say, that extra mindset on how you, yeah, what is actually what you're asking.
Yeah.
And then in the interface between those areas that I quite enjoyed how you dealt with it, we have then the course of dimensionality or the course of the detail in these trajectory models that you have just explored at the end. And I guess that the trajectory model, it's a little bit of trying to bring an ODE, a bit of a formalism of rates of change on how things are deviating, but essentially is to try to fit a phenomenological model into how a parameter is changing in time. So how can those models of trajectory be informed by mechanisms. If you agree with me, the ABC I understood is that OD is going to be a rate of change, it's going to be a constant, it's going to be whatever you feed to the data, but essentially fluctuations can be caused by many things, and I would say you can infer what the
changes happening. Yeah.
So how can you constrain more of those model fittings by more mechanisms, if that makes sense?
It does. And that's exactly the reason why I believe that we need to go further and we need to stop just doing differential equations models, but also physics-informed ones. And the reason for that, it's exactly as you beautiful put it. These models are awesome in finding the changes and the rate of deviations that we have and the progression over time. But they struggle when we have, first of all, too much data, when the data is too different and too heterogeneous, and then they become quite hard to optimize. And often what they start doing, and especially when we start doing neural differential equations, so it's not only a differential equation that we define, but we use deep learning to define these models, they start predicting only the average profile. They start averaging exactly what would be the sequence. So we use them because we want subject specific and we want to capture the differences in terms of time series. And then the model starts doing exactly the opposite. So there is actually where the physics information, it's really handy. If we can start constraining and putting priors, how these models should change, and even assuming that we have subgroups of the population for which these models needs to be optimized, and we can bring these clinical insights from the clinical setting and expertises. So we bring all of this knowledge to constrain the optimization of these models. We start being able to cope and to do the optimization of different curves depending on different populations that we have or different behaviors of the disease. So it's a way of trying to cope with the fact that we don't have all of the data in the world, that even with all of the data in the world, these models struggle and start averaging. So we can have a bit of more subject specificity by including prior information that we have about the subject, demographics. So we start actually modeling what is the influence of all of these clinical variables and knowledge that we have on the data series that we are seeing. And incorporating these two components, it's, in my view, where we should move towards, because otherwise we just might end up with an average model for the population, which more or less we already have in certain cases with event-based models and the other ones.
Okay. But then it's still a bit of a kind of magic that how to bring you call it the physics.
No, it's very hard.
Into the model, but essentially I would understand that that's the question that any researcher is studying a condition is asking themselves: how can I modify this disease? What are the keys of my piano I can play to play the music that is going to change the disease to go away? And that is finding those ingredients of how to constrain the model is an endless loop.
Yeah,
and I guess that my question was going to be, once you start building these models of trajectories, do you generate hypotheses of what should be happening and how to then go back to some experiment and then go back to the model? Is it easy that to trigger those loops, or is it still too heuristic and it's quite difficult?
It's not that easy, I will be honest with you, because we need to find the fine line between constraining too much the model, so it optimizes and it's reflecting what we actually see in clinic, and let the model to be free enough. So then it can start finding the causal relationships. So the issue with the most of the causal models is the fact that we need to make some assumptions while defining them. We need either to define what is the directionality between the nodes in causality, or we need to define the interaction of different variables. So we need to find the fine line where we let the model to be free and actually to pick which causal relationships we want to give more importance and want to define changes in terms of time series. But of course, that if we let that happen, it's an endless system with endless variables. So we also need to bring all of the clinical knowledge to try to restrict that. So that's exactly what happens. And that's what we are working on. It's trying to find this fine line. And at the beginning, we are start constraining it a lot to make sure that the models that we are defining are reflecting what we see in clinics. And then the hope is that we start being a bit more loose in these definitions and not constraining them as much, so we can also allow for finding the causal relationships that we want to constrain the time series itself.
Okay,
It's a
okay.
fine
Strong
line.
apologies for my audience, for the audience that I have not clicked the button of update the questions. There were questions since 8 minutes ago. We have 6 minutes left. Liane is going to be a bit of a press question
Yeah,
time.
I will go quickly.
Can you recommend any R packages for similar analysis for researchers who do not have access to computer scientist collaborators?
I'm very sorry. I can dive into that. Currently, I'm mainly working on Python and Python-based libraries, so I'm not the best person to advise on R, but very happy to check a couple of them and have this conversation offline.
Excellent. That was Kimberly. Kimberly, you reached Liane to close the loop. Victoria, a lot of clinical data is free text and and acronyms, and they don't fit in tabular format. How did you deal with this data? What were the challenges of this?
It is. So basically what we need to do is actually deal with the fact that we need to use natural language processing kind of pipelines to deal with free text. And that's a field of research by its own. It's not something that I work on. I rely on the work from others. Or we try to use encoding directly from the free text by the collaboration with the clinical partners. So my advice, if you are working with this, it's just using the NLP models that already exist to deal with the free text, because they are quite good nowadays, especially we have seen that. So it's something that we can deal.
A quite close question. Self-recorded data tends to be subjective because there are no clear benchmarks. So I was wondering whether this had any impact in the COVID study, and if so, how this was dealt with.
Completely. So the problem with self-reporting data, it's the bias. So one way to try to overcome that, it's with the massive numbers that we had. And that was great. It was the fact that even if some subjects were full of bias in their reporting, the fact that we have such a big sample size that would allow us to accommodate some of these bias and remove the effect from them. And then it was the data curation. Anytime that we establish a new study, we needed to define very clearly what is the aim of the study, what are the sources of bias that we might have, and we needed to exclude lots of subjects that we thought that could have some sources of bias. So if it was post-COVID syndrome and they stopped reporting for 7 days, if they stopped reporting because they don't have symptoms, or if they stopped reporting because they were bored with the app. So unfortunately, we needed to remove them because we weren't sure. So we have two ways of dealing with that. If we are lucky enough with sample size, hopefully that will account for the errors and the biases that brings. And on the other hand, it's all of the boring, let's call it like that, data processing that we need to do before start developing the models themselves.
Okay. We have still 3 more questions, if I'm counting well. We have now Minghua, who asks, based on your experience, is data preprocessing generally more challenging than model development?
Yes, definitely. So it's all about good data for good models. We cannot expect just throw bad things and expect gold at the end. So it can be very challenging, no doubt.
Okay. And have you considered applying forecasting models that are being used in other domains, such as weather forecasting, to predict treatment trajectories in healthcare?
Yeah, definitely. So Gaussian process is one of the type of models that has been used for finance forecasting. It's one of the most common ones, and that's actually what led me to it. And for weather forecast, we also have Bayesian networks, neural networks, and neural processes that have been used. This is this massive, beautiful Google, I don't remember the name of the website, where they do the weather forecast for the full world. And that's a neural processes. So it's a hardcore Gaussian process with deep learning layers to do that prediction. So I have used them before. They work very neatly. The problem is you need good data, and medical data, often it's very noisy. So the performance tends to be a bit worse than the weather forecasting, but they are very useful in that sense.
And we have one last one. Thanks for the talk. For a student interested in this space, what key skills most important to master right now? And in university, we usually get clean data sets. How much of the work was cleaning messy patient data, and what advice would you give students who want to enter this field?
Okay.
So skills mainly here.
So I will start with the cleaning first. So yes, a huge amount of work it's actually to clean these data sets. And that's something that people should focus always. So before start doing any modeling, before start doing anything, look at your data. Do some basic statistics, look at the images, see what could be sources of errors. Often, and there is this case, it's very curious. I will try to be quite quick explaining it. So during COVID, people were using X-rays to predict the outcome of patients. And they found out that they were predicting it because they were seeing the tube in the throat from intubation, and that's actually was what was leading to the prediction. So this is an example why it's so relevant looking at the data and why noisy things can actually impact the performance of the model. This in one hand. For the advice, so my background, it's biomedical engineering. I don't think that you need biomedical engineering to do this kind of models. I think what is very useful, it's linear algebra and a bit of math. I think we need to understand what the models are doing to try to implement them and to leverage the different capabilities and features of different models. So I think that's really useful. And I think as well a bit of computer science, obviously, because you will need to code these models. But more importantly, to me, at least, what helped me a lot. Lots of linear algebra, that's the backbone of machine learning, and a bit of computer science and an engineering mindset. And that means that you need to be a problem solver. So it's not about the topic of your engineering. It's if you are a person that likes puzzles, problem troubleshooting, and a curious mind, and often these components are in the engineer mindset. So that would be something that I would advise you to do if you are looking forward to go into this field.
Excellent. I will highlight now some of the comments that it was a very clear presentation, would be beautiful. Liane, thanks a lot for your talk. Thanks for enlightening us into this field. And thanks all the audience. It's now 3 o'clock. We're going to close it here.